Breastfeeding jaundice often occurs in the first week of life and it's associated with inadequate intake of breast milk. Breast milk jaundice appears a little bit later, usually after the first week of life, and can persist for several weeks. Next type of jaundice, cephalohematoma-related jaundice. Today we are going to talk about types of neonatal jaundice. I'm wearing a yellow dress for this occasion. Neonatal jaundice is a common condition in newborns characterized by yellowing of the skin and eyes due to elevated levels of bilirubin in the blood. There are several types of neonatal jaundice, each with distinct causes and characteristics. Understanding these types is essential for proper diagnosis and treatment. We already talked about two types of neonatal jaundice, physiologic jaundice and ABO incompatibility in previous recordings. Physiologic jaundice, briefly, it's the most common type and typically appears between the 2nd and 4th days of life. It occurs because newborns have a higher turnover of red blood cells and their liver is not yet fully efficient at processing bilirubin. This type of jaundice is usually harmless and resolves on its own within 2 weeks as the baby liver matures. Hemolytic jaundice, ABO incompatibility, results from an increased breakdown of red blood cells, leading to rapid rise in bilirubin levels. It can be caused by conditions such as mentioned ABO incompatibility between the mother and the baby, or by some genetic disorders like G6PD deficiency or hereditary spherocytosis. This type of jaundice often requires medical intervention, including phototherapy, IVIG administration, or even exchange transfusion. Now, let's talk about breastfeeding jaundice. Breastfeeding jaundice often occurs in the first week of life and it's associated with inadequate intake of breast milk, leading to dehydration and increased bilirubin levels. Insufficient breast milk intake can lead to dehydration and decrease in baby's ability to excrete bilirubin through stool and urine. Improper latching can prevent the baby from effectively extracting milk from the breast, leading to inadequate feeding. Delayed milk production. Sometimes a mother's milk production may be delayed, resulting in insufficient milk supply during the first few days after birth. Newborns need to be fed frequently, usually every 2 to 3 hours. Infrequent feeding can reduce the volume of milk intake, contributing to dehydration and jaundice. The primary symptom of breastfeeding jaundice is jaundice, the yellowing of the skin and eyes. Other signs may include poor weight gain. The baby may not be gaining weight adequately due to insufficient milk intake. Dehydration, signs of dehydration in a newborn include fewer wet diapers, fewer than 6 per day after the first week, dry mouth and lethargy, dark urine. Urine may be darker in color, indicating dehydration. Diagnosing breastfeeding jaundice involves history and physical examination, so evaluating the baby's feeding history, weight gain, and physical signs of jaundice. Then bilirubin levels, measuring the baby's bilirubin levels to assess the severity of jaundice. And by exclusion, ruling out other causes of jaundice such as hemolytic disease or infection. And then breastfeeding assessment, observing breastfeeding sessions to ensure proper latch and milk transfer. Treatment and management. Managing breastfeeding jaundice focuses on ensuring adequate feeding and hydration. And key strategies include frequent feeding, encouraging mothers to breastfeed at least every 2 to 3 hours to ensure the baby gets enough milk. Lactation support, providing support from lactation consultants to help with proper latch and breastfeeding techniques. supplementation, if necessary, supplementing with express breast milk or formula to ensure adequate nutrition and hydration. This can be done temporarily until breastfeeding as well established. And monitoring, regularly monitoring the baby's weight, hydration status, and bilirubin levels to ensure improvement. And finally, sometimes phototherapy is needed. In cases where bilirubin levels are significantly high, phototherapy may be used to prevent lower bilirubin levels. Preventing breastfeeding jaundice involves early initiation, so encouraging early initiation of breastfeeding, ideally within first few hours of life. Education, providing education to mothers about importance of frequent and effective breastfeeding. Support system, ensuring access to lactation consultants and breastfeeding support groups to help moms overcome any breastfeeding challenges. Despite the challenges of breastfeeding jaundice, continuing to breastfeed is highly beneficial. Breast milk provides essential nutrients, antibodies, and promotes bonding between mom and the baby. With proper support and management, most moms can successfully breastfeed and overcome breastfeeding jaundice. Next type of jaundice, breast milk jaundice. Breast milk jaundice appears a little bit later, usually after the first week of life, and can persist for several weeks. Breast milk jaundice is thought to be caused by specific components in breast milk that interfere with liver's ability to process bilirubin and inhibits its breakdown. These substances may include a metabolite of progesterone that can inhibit the enzyme responsible for conjugating bilirubin in the liver, free fatty acids, so elevated levels of free fatty acids in breast milk can inhibit something that is called glucuronal transferase enzyme, which helps in bilirubin conjugation, and beta-glucuronidase, the enzyme that can deconjugate bilirubin in the intestines, allowing it to be reabsorbed into the bloodstream instead of being excreted. The primary symptoms of breast milk jaundice is the yellowing again of the skin and eyes, so jaundice again, and that jaundice persists beyond the first week of life. Unlike other forms of jaundice, this jaundice resolves quickly. Breast milk jaundice can last for several weeks, but usually does not cause any harm to the infant. Diagnosing breast milk jaundice involves timing, so observing the timing of the jaundice, which typically starts after first week of life. By exclusion again, ruling out other causes prolonged jaundice such as liver disease, infection, hemolytic condition. Breastfeeding history, assessing the infant's breastfeeding history to ensure adequate milk intake and hydration. And bilirubin levels, monitoring bilirubin levels to ensure that they are not reaching very high dangerous levels. If necessary, temporary cessation of breastfeeding for about 24 to 48 hours may be suggested to see if bilirubin levels decrease, confirming the diagnosis of breast milk jaundice. In most cases, breast milk jaundice is benign and does not require stopping breastfeeding. Management typically includes encouraging mothers to continue breastfeeding as breast milk produces essential nutrients and antibodies important for baby's health. Regularly monitoring bilirubin levels to ensure they remain within safe limits. In rare cases where bilirubin levels are very high, temporary supplementation with formula may be recommended while continuing to express breast milk to maintain supply. And sometimes phototherapy is needed. If bilirubin levels rise to concerning levels, phototherapy may be used to help to reduce bilirubin levels. Breast milk jaundice is generally harmless and resolves on its own over time. The condition does not typically lead to any long-term health issues, and infants usually outgrow the jaundice as the liver matures and becomes more efficient at processing bilirubin. Again, support for breastfeeding mothers is crucial during that time, providing reassurance and education about breast milk jaundice can help moms feel confident in continuing to breastfeed. Lactation consultants and healthcare providers play an important role in supporting those moms and ensuring the baby is feeding well and gaining weight appropriately. Next type of jaundice, jaundice due to prematurity. Jaundice due to prematurity is a type of neonatal jaundice that occurs in premature infants, typically those born before 37 weeks of gestation. Premature babies are at higher risk of developing jaundice due to several factors related to their underdeveloped organs and physiological systems. Premature infants are more prone to jaundice for several reasons. Immature liver function. The liver of premature baby is not fully developed, making it less efficient at processing and excreting bilirubin. Increased red blood cell turnover. Premature babies have higher turnover of red blood cells, which break down more quickly, leading to increased production of bilirubin. Then lower bilirubin conjugation. The enzyme responsible for conjugating bilirubin, glucuronidase transferase, is less active in premature infants, resulting in higher levels of unconjugated bilirubin. Inadequate feeding. Premature babies may have difficulty feeding effectively, leading to dehydration and reduced excretion of bilirubin. We also start feeding them slowly because their GI tract needs to get used to food, and we gradually go up on feedings. Then increased intestinal absorption of bilirubin. The intestines of premature infants may absorb bilirubin back into the bloodstream rather than excreting it. With proper management, so early and frequent feeding to promote bilirubin excretion, monitoring bilirubin levels in the first few days after birth, especially in premature infants. Most cases of jaundice in premature infants resolve without long-term complications. Next type of jaundice, pathological jaundice. Pathological jaundice is characterized by jaundice appearing within first 24 hours of life, so very quickly after baby is born, and it's characterized by a rapid increase in bilirubin levels or a total bilirubin level that exceeds safe thresholds. It can be caused by a variety of conditions, including infections, metabolic disorders, or liver dysfunction. Prompt evaluation and treatment are crucial to prevent complications like kernicterus, a form of brain damage caused by very high bilirubin levels. Something that is very common, next type of jaundice, cephalohematoma-related jaundice. Cephalohematoma is a condition where there is collection of blood between newborn scalp and periosteum, so membrane covering the scalp. It typically occurs due to trauma during birth, such as from the use of forceps, of vacuum extractor, or difficult and long vaginal delivery. How cephalohematoma leads to jaundice? The blood collected in the cephalohematoma contains red blood cells that eventually break down. This breakdown releases bilirubin, increasing its levels in baby's bloodstream. Since bilirubin is produced from the breakdown of red blood cells, cephalohematoma can significantly increase the amount of bilirubin that needs to be processed by the liver. Newborns, especially those with other risk factors such as prematurity, often have immature liver function, making it more challenging for them to process and eliminate the excess of bilirubin. Symptoms of jaundice and cephalohematoma: swelling on one side of the baby's head that does not cross the suture lines of the scalp. The area feels firm and slightly fluctuant. In most cases, cephalohematomas resolves on their own over a few weeks, and with appropriate treatment and monitoring, jaundice related to cephalohematoma can be managed effectively. While neonatal jaundice is common and often benign, it's essential to identify the type and underlying cause to ensure appropriate treatment and prevent complications. Regular monitoring and early intervention are key to managing jaundice effectively in newborns. Thank you, and please address any questions at neonatologyforparents.com.